Good afternoon. Welcome, everyone. This is the January 18th, 2024 Workers' Compensation Roundtable session. And I am Angie Vosing, the president of PACO. And welcome. We are glad to have you with us today. Mike Coughlin from Ohio Reporting. Always good to have one of our sustaining members join us. Good to see you, Mike.
Thank you. You too.
I do have a couple of announcements that I want to go over real quick before we begin. Um, the OSBA Certified Paralegal Exam, that registration is open on the OSBA website from now through March 31st. You do not have to be a member of the OSBA to sit for the Certified Paralegal Exam. So you can register online for that through the 31st. The exam is scheduled for Saturday, May the 18th. If you had seen another date previously, that date has changed. The correct date is now Saturday, May the 18th. And a reminder, PACO does have a study group for the exam. Randy Daniels Blair is heading that up, does a fantastic job with that. Last year, everybody in her study group passed the exam. So yes, it's a quality exam or a quality study group. There is information on the website and in the PACO news. If you need more information, reach out to Randy. I think right now they're meeting monthly still and discussing a different topic every month. And as the exam comes closer, those sessions will accelerate. And I think they're meeting by Zoom. So super easy, super convenient. Again, you don't have to be a member of PACO to participate in the study group. We want everybody to excel and to further their career. So keep that in mind. It's a great way to increase your marketability, get that top-notch job you've always wanted. So think about that. Also, we do have the statewide food drive coming up again this year. That will be from February the 1st through February the 29th. And this year, I believe we have also participating the paralegal associations in Cincinnati, Cleveland, and Northwest Ohio. So it will be the 4 associations that will be having concurrent food drives to benefit their local communities. Here in Columbus, everything that we collect will be contributed to the Mid-Ohio Food Bank. We are going to be collecting non-perishable food items, and there will be an option for monetary donations if you'd like. That will be up on our website in February. We currently need collection sites. We will provide a box and the signage. Ask your attorneys, ask your managing partner in your firm if they will serve as a collection site, either for offices in your building or just for your firm alone. Any little bit of contribution will have a big impact, and we encourage everybody to participate in this. Let's see. The other big announcement, we are having our next happy hour on Thursday, February the 8th from 6 to 8 at Getaway Brewing Company in Dublin. And the first 10 paralegals to attend and bring 10 or more non-perishable food items to contribute to our food drive will receive a free drink ticket for the evening. We would encourage everybody that brings to bring 1, 5, 10, 20 non-perishable items, however many you would like to bring with you. That would be much appreciated. Okay, that is all of the announcements that I have. So let's go ahead and introduce our speakers. We are very happy today to have with us Bradley J. Lewis, MD. He is the Chief Medical Officer of the Bureau of Workers' Compensation. He joined the BWC as Chief Medical Officer in February 2020, following a long career in family practice and more than a decade of public service. He oversees all medical components of the BWC and directs medical policy. His roles in public service include Franklin County Coroner from 2000 to 2008, Groveport Village Councilman from 1993 to 1997, and an independent contractor for the state agency Opportunities for Ohioans with Disabilities. Dr. Lewis has served on the Board of Trustees for Columbus State Community College and the Board of Directors for Maryhaven. He is a graduate of the Ohio State University College of Medicine, where he later served as a clinical instructor and assistant professor, and completed his residency at Mount Carmel Medical Center in Columbus, Ohio. Also joining us today is Dr. Tracy Archibald, who is a Doctor of Pharmacy graduate of the University of Findlay. Before joining public service, Tracy worked as a retail pharmacist for 6 years throughout Ohio and in New Bern, North Carolina. Her role in public service began at the Ohio Department of Medicaid, where she worked as a pharmacologist and strategic initiatives director for 4 years. Tracy joined BWC in August 2021 as the director of pharmacy. She leads the pharmacy department to ensure Ohio's injured workers receive appropriate, safe medications. Thank you both for being here. We appreciate very much your sharing your time and your expertise, and we look forward to what you have to share with us today. I believe you are going first, Tracy, so I will give it to you.
Great. Thanks, Angie. Thanks for having me, first of all, and for that introduction. Happy to share a little bit about kind of what we're doing here at BWC with you all today. So primarily today, I'm going to be talking about opioids. And just to level set a little bit, some of the commonly prescribed oral opioids I have up on this slide here. So they're probably terms that you've heard maybe before, but just wanted to make sure everyone kind of has some knowledge about what I'm talking about. So there are both short-acting opioids. These are ones that are generally taken like every 4 to 6 hours for pain. And then we have our longer-acting agents. These are usually for individuals who are on like a long-term treatment plan for needing pain medication. So they're usually dosed once or twice a day. Just something to note, it does come up sometimes. OxyContin, which is an extended release form of oxycodone, was removed from the formulary back in 2019. So as far as our opioid prescribing trends, as you can see in the last 10 years, we've had significant decline in the number of injured workers as well as the number of prescriptions that we are paying for opioids. So in the last 10 years, we've seen about a 78% decline. That's multifactorial. Our first and foremost, our state of Ohio has done a lot of work as far as implementing new laws and rules, limiting prescriptions and prescribing of opioids. Also in workers' compensation in general, we are seeing less injury claims as jobs become safer. So that's always good too. But as you can see, quite a change in the last decade. This has just links to all of the rules in Ohio Administrative Code related to pharmacy. We have our payment rules, our formulary rule, and our first fill rule, just to kind of point out a couple of the common ones that we use. So another kind of level set before diving into this, a term that I'll be using is morphine equivalent dose, or MED. So what this does is it tries to essentially standardize the amount of opioid that someone is receiving. And so they use morphine as kind of the standard, and then depending on the potency or how strong the other opioid is, it gives it a conversion factor. This is a way that no matter what opioid someone is receiving, we can have a general idea of what their level of MED is. And generally, as the MED increases, that's when we're going to see the increased likelihood of adverse effects of opioids, like respiratory depression, But also it's strongly correlated with, you know, long-term consequences as far as becoming dependent on opioids. And the Centers for Disease Control, the CDC, creates those conversion factors used. So going in a little bit to our prescribing rules for opioids. So just a little background, BWC, and this is before my time, so I can't take credit for it, but BWC was actually one of the first state agencies to really implement some rules around limiting the prescribing of opioids. Now the the medical board has actually adopted these rules. And so now our rule just kind of points back to the medical board. So they really maintain kind of what the standard is, but we do have a few caveats. So I did want to walk through this with you all. So a couple things to know: acute pain versus chronic pain. There's also something called subacute. So the difference in those terms has to do with how long you're using an opioid. So acute is generally limited to less than 6 weeks of treatment. Subacute is that period between 6 and 12 weeks, and chronic is anything over 12 weeks. So that can be kind of important when we're talking about opioids. And so acute pain prescribing, we see this a lot, obviously, you know, when when someone's getting discharged or went to the ER. So this is really kind of what those are related to. But the reimbursement for opioid prescriptions, again, has to comply with the medical board rule. The subacute and chronic, same thing. We're pointing to the medical board rules, but there are some distinctions within the rule and within the medical board rule and our rule related to prescribing at different levels of MED. So that's why I wanted to kind of level set on what MED was. And essentially, as the MED increases, we have more kind of requirements that we want to make sure are being met to ensure the safety of the injured worker. So once an injured worker is at that 50 MED level, that's kind of the first sort of check-in. And we want to make sure that in addition to everything, the medical board rules requiring that we have a validated risk assessment and that the injured worker is also having urine drug screens. I'm going to go into this a little bit more, so I'll just kind of breeze through these here. But in reference to what these checkpoints are, so if it's less than 50 MED, but they've been on it for more than 6 weeks, then at that point, our pharmacy department, we're going to make sure that we've got a current history and physical on file. Usually that's at least once a year, but generally every 6 months is ideal. That they have noted the functional pain assessment and sort of what their longer term treatment plan is. We also want to make sure that prescribers are checking ORS. That's the Ohio Automated Reporting System for Controlled Substances in Ohio. After, once they've reached that 50 MED marker, we want to look and make sure that the physician is reevaluating the overall status of the injured worker and obtaining a written informed consent. So they're making sure that the injured worker is aware of the risks of taking opioids long-term and at a higher dose. There's also an opioid risk assessment that we look for. That's every 3 months, and I've got more detail on that in a little bit. And then, as I mentioned, the urine drug screen. Based on the risk assessment, that sort of guides the prescriber on how frequently they should be obtaining a urine drug screen, as well as if they would be random and things like that. 80 MED is the next checkpoint. This is getting kind of on that higher end of MED where we start to have concerns with things like respiratory depression, especially if you're adding on other medications like medications for anxiety. So at that point, we want to make sure that there's an actual pain management agreement between the injured worker and the doctor. Usually this involves stating that this is the only prescriber that will prescribe opioids for this individual. And so it's a written contract that essentially outlines all the requirements that that provider has and that that injured worker needs to follow and agree to in order to be seen at that office. At this point, too, it's also required to offer an opioid reversal agent to the patient. So that's Narcan or naloxone. And then after you go above 120 MED, the prescriber needs to be board certified in pain medicine or needs to have a recommendation via direct consult with a physician board certified in that area. So as far as the MED, this is actually available on the Board of Pharmacy's website through ORS. And this is a calculator. So if you're not sure where someone's falling in, the provider can simply go onto this tool here and put in how many milligrams per day of which drug the injured worker is taking, and it'll actually spit out how many morphine equivalents. If they're taking more than one agent, it'll add it up too for you. But so, a common dose of an oxycodone prescription, either like 10 milligrams 4 times a day or 20 milligrams twice a day, something like that, would come out to be 60 MED. So just to kind of give you an idea of kind of a typical level that we might see.
And I'm sorry, where did you say, what website did you say you can find that on?
It's through the Board of Pharmacy, and I have the link in my in the notes section of my PowerPoint, so I can get that to you.
Okay, thank you.
Sure. So the validated risk assessment that I referenced, this is one of the ones we see most commonly. It's called the opioid risk tool. And it's just a brief report that the prescriber can ask the questions to their patient, and it essentially kind of stratifies what their risk would be for opioid abuse. This is primarily for someone who's going to be on opioids for more than 6 weeks. And it can help categorize if someone's like at high risk for any kind of drug abusive related behavior. And it's really quick and easy. It's only about a minute long. So this is an example of a validated risk assessment tool. And as you can see here, it's just asking a few simple questions about their family history, their personal history with other substances, and then any psychological conditions that this person might have. And it should be administered at their initial visit to get like a baseline, and then it should continue on throughout their therapy, and we require them every 3 months. So a score of 2 or lower is considered low risk, and then anything 3 or above would consider a higher risk. So that's kind of all related to what the rules are as far as the Ohio Administrative Code. Those are the requirements of the medical board as well as the Bureau of Workers' Compensation. In addition to that, we do have some specific formulary limitations. So for the first fill of an opioid, an injured worker is allowed up to 7-day supply or 30 tablets, whichever is less. We do see this a lot. This is within the guidelines of kind of what urgent care and emergency doctors are limited to, but every now and then we'll see someone trying to fill a prescription for like 42 tablets or something. So these are good numbers to know. If someone's like getting their first time opioid, 7 days or 30 tablets, that's going to be the initial limitation. We also limit short-acting opioids to up to 6 tablets per day. And they can only have one short-acting opioid at a time, or one, and then also the long-acting opioids are limited to 1 at a time as well. These are the current formulary limitations for our long-acting opioids, and we have a few different tiers. So at each tier, Tier 1, is kind of where we want people to start. And then we would need to see a trial and failure of 2 agents in the tier to proceed to the higher tier. And then we do have some exceptions, of course. So in post-operative situations, if someone's having a surgery, what prescribers can do is proactively submit a medication request, which is a prior authorization prior to the date of the scheduled surgery. This allows us to enter in the authorization for any post-op medications. We enter those in up to 5 days before the scheduled surgery and then 30 days after the scheduled surgery. So we can put in those overrides for the limitations, such as overriding if they won't need to receive like an extra dose of a short-acting opioid, maybe a different strength at a time. That's kind of the biggest limit that we see that usually needs to be overridden. And that is generally because if someone is regularly taking opioids and they have a surgery, then generally they're going to need, some additional dose to get them through that first couple of days after surgery of increased pain. And then also sometimes we do have injured workers that are not opioid naive. And opioid naive is considered that you have not had any opioids in the last 120 days. But if an injured worker is already on opioids and it might be by another payer or something, we can actually verify that through the state reporting system, or to verify if they're not opioid naive, then we can override that initial limitation of 30 tablets or 7 days. And then another thing that we do, we send out a product called DisposeRx to any injured worker that is receiving an opioid for the first time in 12 months, or anytime we've done an override for like those post-op medications where someone's getting additional doses of opioid. Essentially, it's like a crystal light packet you can see here in the middle of the screen. All the injured worker has to do is fill their vial with the unused medication with some water and then put in that packet. They shake it up and it congeals essentially into like a non-toxic substance that can just go straight into the trash. These are pretty inexpensive and we feel like it's a good way for someone, if they have leftover medication, to dispose of it safely. A lot of times, people in someone's house, it could be a teenager or any family member might have access to someone's medicine cabinet. We don't want anyone getting their hands on something that isn't meant for them. So this is a great way to help safely dispose of any unused opioids.
And that's something that the BWC directly distributes?
Yes.
Do you have any information on whether, for instance, self-insured employers would also be providing these?
That's a great question. I'm not sure if they provide this exact product. There are products that pharmacies have sometimes where it can either be like a bag that can be mailed back, or they might have like something similar to the DisposeRx product at the pharmacy, and the pharmacy can usually bill for that directly to the PBM for the self-insured. So I'm not sure whether or not they would cover it, but pharmacies would have the capability, if that's something that they can order, that they could try or dispose or dispense with the opioid prescription.
Okay, thank you.
Sure. So again, we'll provide the slides, but these are just some links to some resources that are available from the state. And then I also wanted to let everyone know that we put out a newsletter every month. It's called our Provider Update, and it just provides a lot of really great information as far as what's going on with BWC and what if there are any changes coming about. So if anyone's interested in prescribing, all you have to do is just send an email to this email address here, and this can be shared with anyone. It's called the Provider Update, but you don't have to be a provider. It's just good information to have If some of you are familiar, we used to have a publication called Rep Connect. That's actually going to be kind of merged into this. So there's lots of good information in there. I provided a link to the most recent update, but again, they're released every month. So just something that you can all take advantage of.
Great, thank you.
You're very welcome.
Does anybody have any questions for Dr. Archibald? Okay, well then we will let Dr. Lewis.
I have one.
Okay.
It's sort of a oddball. It's just more of a curious question than anything.
Sure.
And sort of outside the scope of what you talked about, but I'm curious how palliative or hospice care falls into this. Because obviously there's higher dosages there. And are there any carve-outs in the law or rules? And are there any potential loopholes for abuse in there?
Yeah, that's a great question. Thank you for that. Hospice is generally exempt from the medical board rules, so they are not subject to those limitations. Or if the person has a diagnosis of a terminal condition, then they're not subject to that. We see very high doses of morphine used in palliative care and hospice, and there's lots of evidence to show that that is beneficial for those people, so they are exempted.
Great, thank you.
Yeah, thanks for the question.
Okay, Dr. Lewis.
Okay, I share my screen here. Let's see what happens. Did that work?
It sure did.
Oh, okay. My name's Dr. Brad Lewis, and we're going to talk about some alternatives to using the pharmaceutical products that Dr. Archibald just spoke about. BWC has an overriding philosophy. We want injured workers to get the right treatment in the right setting for the right condition and at the right time. So, the right setting might be, do you need to be inpatient or outpatient for your surgery? Can it be done at a surgery center or at a hospital? Obviously, we want the treatment to be tailored to your specific condition, and we want it to be given at the right time. So if you're requesting spinal fusion therapy, that probably isn't the first step in your treatment. We want to make sure you've tried some other more conservative things before we get more aggressive. So the big question is the right treatment and what constitutes the right treatment. So for BWC, the treatment has to be safe, it has to be efficacious, it has to work, and it should be cost effective. So safety and efficacy are the two major things we look at in treating pain and whatever modality we use. And we have to look at risks versus benefits of any treatment. And we want, obviously, the benefit to outweigh the risk. So we are not against the use of opioids per se at BWC, as long as it follows the rules and can meet the standard of safety and efficacy. There are certainly benefits to opioids. They reduce pain. They can help increase the quality of your life. They can increase your function. But there are also risks. They cause sedation. There's a higher propensity to falling. There's a risk of respiratory depression. There's a risk of interacting with any other drugs you're on. So that's what we kind of have to balance when we look at the use of opioids in our injured workers. But we don't have to rely on opioids necessarily. BWC may reimburse for multiple non-pharmacologic methods of treating pain. And these include, chiropractic treatment, physical therapy treatment. A lot of people don't realize that BWC may pay for massage therapy, TENS units, spinal cord stimulators, nerve blocks, trigger point injections, and we also will reimburse for acupuncture in the right setting. So we'll discuss each of these, and we'll kind of go from the least invasive to the most invasive alternative to pharmacological therapy. So first thing we'll talk about is chiropractic care. And the thing that sets chiropractic treatment apart from physical therapy or massage is that the chiropractor performs adjustments or manipulations to the spine or to a joint or whatever part of the body may be affected. They'll usually do this manually with their hands. Sometimes they'll use some instruments, and the method is a controlled, sudden shift in alignment to readjust the physical status of the body. And by adjusting that alignment, whether it's in the back or some other joint, the goal is to help eliminate or ease pain and to help the body to heal. And let me just comment here. It does say ease pain. Elimination of pain is very rare. Most people are going to have pain to some degree. We want to minimize the pain. We want to keep you functioning with the pain, but a pain-free existence is definitely the exception and not the rule, whether you're a workers' comp claim or any other claim, type of medical claim, or if you have no medical claim. So what do you have to do to be a chiropractor? You have to graduate from chiropractic college. You have to be licensed by the state of Ohio, which will come after you pass a national board exam. And you're governed by the state chiropractic board. So if there are any quality issues that arise, the state chiropractic board will hear any allegations of inappropriate conduct or malpractice. Physical therapy is a little different. They don't rely on manipulation and adjustment, but physical therapists are going to use more stretches and exercises to help recover and maintain maximum abilities and movement. They may use different devices to help accomplish this. A physical therapist will also kind of do an assessment of what your baseline function is and how you're improving. And again, they're focusing on muscle and joint strength, mobility, and the ability to function. And physical therapy treatments are usually, multiple treatments over a set period of time. So physical therapists have a master's or a doctorate degree from an accredited college. They also have to be licensed by the state of Ohio, and they are governed by their own board, the Ohio Occupational Therapy, Physical Therapy, and Athletic Trainers Board. So again, if there's any issue with quality of care or a malpractice, it would be this board that governs the physical therapists. Most people don't realize that workers' comp may cover massage therapy. And there are two types of massage recognized in the state of Ohio. The first is therapeutic massage, and this is practiced by a licensed massage therapist. And these therapists are governed by the state medical board. So there are state rules that a licensed massage therapist is required to follow in order to deliver therapeutic massage. So what exactly is the definition of therapeutic massage? It's, again, manipulation of the soft tissue, muscles and ligaments by applying external pressure, usually with the hands, sometimes with other objects like a ball or some other things. You're looking at, stroking, touching, percussion, kneading the muscles to help get relief of pain and tension in the muscles and the ligaments. Non-therapeutic massage, again, is not recognized in Ohio. This is also referred to as relaxation massage. And you don't have to be a licensed massage therapist to perform this. The state does not regulate unlicensed or relaxation massage. This is regulated on a city or a level or a locality level, if at all. Some cities choose to have regulations for relaxation massage, others don't. So this is not reimbursed by workers' comp because its intention is not to treat any specific health condition. It is more relaxation. So I'll let you, I won't comment further on the means of relaxation. Now we are getting outside of just the physical therapy, chiropractic, and massage. We'll talk about things that are a little more intrusive. So a TENS unit, which many of you have probably heard of and maybe even used, is short for transcutaneous electrical nerve stimulation. And this consists of a battery-powered device that kind of looks like an old-fashioned Walkman, if you're as old as I am. And it has electrodes, little patches that are attached to it by wires that are placed near trigger points or affected nerves or the area that you're experiencing pain. And the little device, the battery sends electrical current through the wires to these adhesive pads to the areas that you're experiencing problem with. So why does this work? Well, all of the nervous system is basically an electronic system. It works by conducting electricity through nerve cells. So by introducing this external electrical stimulation, it helps to block the transmission of pain signals and alter the way you're perceiving pain. And there's some indication that the electrical stimulation may also rise the levels of endorphins in your body, which are chemicals that kind of help you feel better and help minimize pain. So, runners will often talk about hitting an endorphin high after they've run for so long or so intensely. That is nothing I've ever experienced, so I'll have to take their word for it. But that is the theory behind the TENS unit. And the intensity and the frequency of the pulses can be adjusted to deliver maximum benefit. So dry needling. This is something you may not be as familiar with, but we'll talk about dry needling and acupuncture because they are in many ways similar, but there are some differences. And this is obviously a more intrusive alternative to pharmacology therapy. So this is associated with pain due to a trigger point. The trigger point is that sore area of knotted muscle that you develop in an area that's being overused or that's been damaged. They're very painful when touched or pressed on. They may be located near the source of the pain, but they can also cause referred pain. So they could also be some distance away from the area that's actually hurting. And the theory is that these trigger points are caused by either acute trauma or chronic, smaller micro trauma. It stresses and can damage the muscle fibers and causes them to contract, and that's why you get this knot of muscle. When you get this knotting of your muscle and this continued contraction, it starts limiting the amount of blood supply, and it also eliminates the energy, the glucose that you're using to supply the muscle. You start getting a buildup of lactic acid in that area. And the combination of the increased acidity and the decreased oxygen causes the nerves to be sensitized, and you start experiencing pain. So what dry needling consists of is stimulating that trigger point, that knotted group of muscles, with a very thin, almost hair thin needle. And that is thought to help bring blood flow back into that area of trigger point and tension. And with that increased blood flow, then you're flushing out the lactic acid and you're introducing more oxygen. It will also, the needle will also help trigger off some nerves. And just like the TENS unit, that stimulation of those nerves can release endorphins to help eliminate the pain as well. So dry needling, as you'll see, is going to be very similar to acupuncture, and we'll talk a little bit about the differences in the upcoming slides. But from a patient perspective, it's pretty much the same. Someone's putting needles into your body, and the theory behind it is different, and where they put those needles is different. But from a patient perspective, dry needling and acupuncture is very, very similar. So who can perform dry needling? Well, acupuncturists can also perform dry needling, and we'll talk about the differences. Physical therapists can perform it after taking additional in-person training, and MDs, DOs, and chiropractors can all perform dry needling as well. So acupuncture is slightly different than dry needling. Dry needling is a Western-based medicine. And again, you're putting your needles in the trigger points, those tightened, anoxic, hyperacidic areas of muscle. Acupuncture is based on Eastern medicine, and the location of the needles is based on the Chinese concept of the flow of energy through your body, which they refer to as qi. And there are different meridians in your body through which this energy is thought to flow. And there are hundreds of acupuncture points along these 14 major meridians or energy carrying channels. And that is where the location of the needle would go in acupuncture. Energy flow and this kind of thing may seem to be a bit sketchy to a lot of Western people, but acupuncture has been shown to help relieve pain and help quality of life. So acupuncture training is a little different. An acupuncturist has to complete some pretty extensive training, 1,725 hours from a program accredited by their accrediting organization, the Accreditation Commission for Acupuncture and Oriental Medicine. But in addition to acupuncturists, MDs and DOs can also perform acupuncture, and chiropractors can perform acupuncture if they receive an additional 300 hours of training in the procedure. Trigger point injections. So this is kind of similar to dry needling, except it's not dry. You're injecting something into that trigger point. And that is either a corticosteroid, like a typical one would be like Kenalog or Marcaine or cortisone. And that steroids are strong anti-inflammatories. So by injecting them into the trigger point, it's going to help eliminate the inflammation in that area. That's often combined with an anesthetic. So something like Marcaine would be a injectable anesthetic, and that purely eliminates pain and numbs the area. So you can do a trigger point injection either with a corticosteroid alone or with an anesthetic alone, but typically they're combined into a single shot. So the two are mixed together, injected into the trigger point. The anesthetic's going to relieve the pain, and the corticosteroid is going to relieve the inflammation. And this may provide long-term relief or short-term relief, depending on the underlying etiology of the condition and the patient. Now, another thing that can be injected is botulinum toxin or Botox. But most people think of Botox as a cosmetic product, but botulinum toxin comes from the botulinum bacteria, and it is a paralytic and a muscle relaxant. So it is used to inject the trigger point to get rid of that prolonged muscle spasm, help the muscle relax. And again, depending on the underlying etiology of the condition causing the pain, it may produce long-term relief, but oftentimes it's short-term relief, and it has to be repeated at various intervals. Nerve blocks are more invasive yet because you're not injecting just into the muscle. You're going through the muscle layer of the body, and you're injecting around the actual nerve that is causing the pain. Oftentimes, this injection is directed. They may use an ultrasound or a fluoroscope or a CAT scan to help guide the needle into the proximity of the nerve they want to treat. It's an outpatient procedure, and again, may produce long-term relief, but often it's going to be only a short-term relief, and the nerve block may need to be repeated. The relief that it does provide is very quick. The anesthetic and the anti-inflammatory medicine is going to provide quick relief. The question is how long that relief will last. So it may resolve your problem in a single injection. You may need multiple injections for addressing your problem. The other thing about nerve blocks is we're talking about them here to treat pain, but nerve blocks can also be diagnostic too. So if a physician is concerned about exactly where your pain is coming from, if they do a nerve block, and you get pain relief, they know that is the nerve causing your problem. And then the question is, do we need continued intermittent nerve blocks, or do we need more aggressive treatment like surgery? There are a couple different types of nerve blocks. We kind of think of them in two categories. Peripheral nerve blocks would be like a pinched nerve in one of the distal areas like your arms and legs. More central nerve block is going to be like an epidural into your spinal area, or either adjacent to the spinal cord or just outside the spinal cord to help relieve the pain. So spinal cord stimulators are a lot like TENS units, but they're internal. So again, you have a battery operated little pack with electrodes that lead to specific spinal cord nerves or into the spine itself, into the epidural space. The little battery pack is usually is implanted under your skin. It's usually in the abdomen or buttocks area, because there's more soft tissue there to implant the area and make it less uncomfortable and less noticeable. And like a TENS unit, the degree of the intensity of electrical pulses and frequency can be adjusted. In this case, it can be adjusted remotely with like a kind of remote control device. So they can adjust the frequency and the intensity to help disrupt the electrical signal from the pain center to alleviate the pain and change your perception of pain. Now, and again, increase endorphins as well. Now, obviously, this is a more invasive procedure. So what will typically, and BWC has a specific rule to guide the use of spinal cord stimulators. And again, we aren't against them. We don't necessarily want to dissuade them per se, but we know there are some things they work better at than others. So literature shows that a spinal cord stimulator rarely helps a problem originating from the cervical nerves, the nerves in your neck. They're much more likely to help in the lumbar area. So, we would want it to be treating that condition. Part of that rule is for the physician to outline the different risks and benefits of a spinal cord stimulator. And this goes back to the pain-free concept. If you get a spinal cord stimulator, you will not be pain-free. You will hopefully be in less pain, and your pain will allow you to function better. But it is very, very rare that your pain is eliminated. The other thing with spinal cord stimulators, like the nerve blocks and some of the other things we talked about, is over time, their efficacy starts to wane. So usually after 7 to 10 years, the effect is going to increasingly get less and less. And the other thing is, since this is a surgery, there are certain risks to the surgery, risks of infection and abscess and things like that. So we just want the patients to have reasonable expectations, know the risks, know that this isn't a panacea. And because of those areas, not only BWC, but virtually any situation calls for a temporary spinal cord stimulator. So you'll have a temporary stimulator implanted for 1 to 2 weeks to see if it works. If it works, then you go ahead and get your permanent stimulator. And that's kind of, we didn't get into surgery, obviously, because surgery is always kind of the last resort. So I really haven't discussed surgical procedures, but suffice it to say, surgically, you're doing very similar to something like you're doing with a nerve block often, except you're severing the nerve to eliminate the pain. And that's pretty extreme and a last resort type of thing. Spinal surgery, you're usually trying to eliminate the pain by removing any pressure on a particular nerve. So with a herniated disc, you'd be doing surgery, if necessary, to remove the portion of the disc or bone that's pressing on the nerve. But interesting, and not to get too far afield, herniated discs usually get better on their own. So this goes into treating at the right time. 90% of herniated discs resolve within 10 weeks. So that's why we don't rush into things like surgeries. So kind of in summary, BWC offers multiple varied non-pharmacological treatments in addition to the pharmacology treatments that Dr. Archibald spoke about as options to help minimize your pain, get your function increased, and make your quality of life better, and hopefully get you back to work. And I'll be happy to take any questions.
Thank you, Dr. Lewis. I do have a question on the spinal cord stimulators, and it's a two-part question. I know that prior to having a spinal cord stimulator implanted, there is a psychological evaluation that's required. And I know a lot of that focuses on their risk for, making sure that they understand the limitations and have accurate expectations of what is going to the benefit of the stimulator. And I know they do a serious evaluation as far as risk for medication for abuse of medications. But and then you said also, so I guess I wonder if I have a correct understanding of that. And then also you said that it won't take away all of the pain, that you'll still have pain. So I'm wondering what kind of a reduction in pain medication should you expect to see? If somebody says they're having 70%, 80% relief with their spinal cord stimulator, what kind of reduction in pain medication should you expect to see?
Sure, those are all great questions. We do require a psychological evaluation with spinal fusions and spinal cord stimulators. And the reason for that, again, is the expectation of how well they're going to work. Literature shows that people suffering from untreated schizophrenia or bipolar disorder are probably not going to have good success with a spinal cord stimulator. Now, the emphasis there is untreated. So if your bipolar condition is under control and treated, if your schizophrenia is treated and under control, then you still may be a candidate for a spinal cord stimulator. And those rules apply to a lumbar fusion as well. And again, it's because we want to maximize the opportunity for a good outcome. You should, as far as how much reduction in opioid therapy you will experience, that is very individualized. And that goes in part to why we do the spinal cord stimulator trial. That will give you a good idea of how much pain relief you're going to have. And, ideally, with that pain relief, we're going to be able to taper down on your opioid therapy. Now, it is very unusual to be able to eliminate all opioids, even with a spinal cord stimulator. So chances are you're going to be getting both therapies, but you'll be on a significantly lower dose of opioids. And with that lower dose, you have a lower risk of the things we talked about: less sedation, less falls, less drug-drug interaction.
Okay, great. Thank you. Does anybody else have any questions for either Dr. Archibald or Dr. Lewis? Okay, well, we are about out of time. Dr. Lewis and Dr. Archibald, we want to thank you again for joining us for today and for sharing your time and your expertise. We want to thank all of our members for attending today and for your time and attention. Let's see. Well, he has already logged off, so he's going to miss his plug. Attorney John Bauer joined us today also. He was curious as to what the presentation would be, what information would be shared. He is going to be joining us next month on Thursday, February the 15th, again at noon by Zoom. And he will be discussing the nuances of Ohio Administrative Code 4123-6-21.7, the rules by which providers are required to follow in prescribing narcotic or opioid medications in workers' comp patients, and how an employer can gauge whether these rules are being followed, and what you might be able to do to try to decrease the need for opioid medications in a claim. And also he will be discussing with us the rebuttable presumption defense of workers' comp claims when you have an injured worker who tests positive for illegal substances at the time of their injury. So that will be very interesting. Thank you again, Dr. Archibald and Dr. Lewis. This was very interesting, very informative. Good information to have with us. And we also want to thank Spectrum Reporting as well for providing today's Zoom link and recording today's session. The session will be up on the website in probably 3 to 4 weeks. So if you want to go back and review, that will be under the members only video library tab. So with that, I will thank you again for attending and hope everybody has a great day. Thanks so much.
Thanks for having us. We
Yep,
appreciate it.
thanks for
You're
having
very
us.
welcome. You're
Bye-bye.
very welcome.